If I had been born 2 centuries earlier, I would have been the town crier. All right, let's resume. So we're going to talk about proposed recommendation text for the policy options. However, before we do that, Dr. Fry wishes to offer additional comment. Then Dr. Kohler will come back from Merck to offer comment, and then Dr. Damon will introduce the next, Dr. Craviotta. So go ahead, Dr. Fry.
Thank you. Before we start the next session, I just wanted to make a couple quick comments. I just want to remind everybody that we are talking about a live attenuated vaccine vector, namely VSV, in its recombinant state. But with live attenuated vaccines comes a different set or more side effects than we see, for example, with subunit vaccines. And those include things like fever, myalgias, and arthralgias, so they're frequently not unexpected. I just wanted to make that point. Also, I wanted to also talk about transmissibility just for a second. We don't have there's not much data on transmissibility as far as this vaccine is concerned. It hasn't been well studied, so I know that people have concern about transmissibility, but you know what we know, and it's not, we don't have any evidence for it, but we do have evidence for skin lesions that have virus in it and other fluids with positive PCR testing. Our recommendations are going to be population-based. They are not being presented in the sense of shared decision-making. The decision-making processes will be at the level of the institution, but again, we're talking about population-based recommendations for this particular vaccine, given the mortality related to the infection should someone become infected. Dr. Kassaboom will make some comments about arthritis and arthralgia to answer previous questions at some point in this presentation. Thank you.
Dr. Kohler, please.
Yes, thank you. Ooh, okay, thank you very much. Thank you for the opportunity to actually take some time to run and look up some numbers, and I'll complement what Dr. Kassaboom is going to share with you. In terms of arthritis, so data from our largest phase 3 double-blind, placebo-controlled US-based study, I can share with you that there was approximately 3.7% of subjects developed arthritis who received the target dose. The median onset for that was 11 days post-vaccination. The median duration of the arthritis was 6 days, with a range from 0.5 to 44 days for the target dose and 0.5 to 156 days for the high dose group that was included in that study. Nearly all of the arthritis events had resolved prior to the 6 months, and there were no recurrences out to 2 years. So there were a subset of subjects, about 500 subjects, who were followed for 2 years out of a total of 1,200. So that gives you an idea of the data coming from our largest US-based study for arthritis. For arthralgia, there was a lot of variability. It was assessed across all of the trials. In the phase 1 blinded trials, it ranged from 10 to 50% versus 22% in placebo. On our US approved label, that number is 18%. So I just wanted to clarify that when I was asked that question earlier. Median onset, it tended to occur quite early, within days, and was generally resolved by day 14 for arthralgia. There were some that went longer than that, but generally resolved by day 14. So as we at Merck talk about it, the arthralgia was generally days to weeks, and the arthritis was more weeks, extending out to months in some cases. So hopefully that's helpful. And then Dr. Kassaboom.
Thank you.
Thank you so much, Dr. Kohler, for providing that context, and I think it covered all of the things that the committee members were interested in. I just have a little bit more background to add on. As we discussed, the Geneva trial was the first trial to identify arthritis, and they provided very extensive investigation into the cases. So to add on to what the data she provided, there were, as we showed in our data, 24 cases of temporal associated arthritis in this trial out of 102 subjects. And the median duration of the arthritis was 34.5 days. It had a median time of onset of 10.5 days. And of those 24 subjects with arthritis, 5 of them reported recurrent arthritis or arthralgia. And that had a duration ranging from 3 to 222 days, with a median duration when taken together with those recurrent reports of arthritis of 81.5 days with those recurrent cases. So I just wanted to provide that as additional information. Regarding the question of the risk ratio that was reported in the slides for arthritis for outcome 4, I did discover that there was a small arithmetic. I struggle with addition sometimes, and so it makes a minor change, but that's related to your question of that risk ratio. So that'll be updated for the final slides, but it wasn't significant as you mentioned. Thank you.
Thank you very much. Dr. Damon, Dr.
So I think there had been some discussion at some point about the potential for people with cardiac risk factors. And so I was wondering if we could impose on our colleagues from the SAGE who've been following the WHO efforts to look at safety in the data, and also our colleague from FDA to talk about what they've seen in terms of any cardiac risk factors or adverse events.
Dr. Carviota, please.
Thank you. Good morning, and thank you for the invitation to be here. We haven't received any information regarding any cardiovascular effects. The main adverse effects that have been reported in the trials or in the use of the vaccine in the DRC has been mainly arthralgias, probably because of the way the vaccination has been done and the follow-up difficulties. We haven't seen the arthritis part in that sense, but there have been no cardiovascular events. What I would recommend also is that the Global Advisory Committee on Vaccine Safety has just published this week its newest bulletin that includes the whole analysis of safety data for both the VSV and the 826 Ebola vaccines that are available in the WHO webpage if you want to look at them in more detail.
Thank you, sir. Dr. Fink?
Right. So in the safety data that we reviewed for the licensure application, which included approximately 16,000 adult subjects who received the vaccine, there were no reported cases of myocarditis or pericarditis specifically, and more generally, no signal to suggest any cardiac toxicity related to the vaccine.
Thank you. Okay, so we're now going to go on to Dr. Choi's presentation regarding the proposed recommendations for text for policy options. She will run through each of the 3 proposals, and then we will circle back around and discuss each of these individually as necessary.
Okay, so the first vaccination policy issue for consideration today has to do with individuals responding to an outbreak. Again, we're limiting our conversations to vaccination in healthy, non-pregnant, non-lactating adults, 18 years of age or greater. And the question is, should pre-exposure vaccination with the vaccine, with the VSV vaccine, be recommended for individuals in the U.S. population responding to an outbreak of Ebola virus disease due to Ebola virus species Zaire? And amongst our work group, the proposal by strong majority is recommend. The reasoning that was given for this recommend was documented history of infections and outbreak responders, that the benefits of vaccination outweigh the risk given the severe disease and no currently FDA-approved treatment, and that there is always a risk of exposure even with appropriate use of personal protective equipment. As we all know, it's not always what you wear, but it's about how you wear it and how you take it off. So there's a risk there. And the proposed text for this population is as follows. Pre-exposure vaccination with the RVSV vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older in the U.S. population who are responding to an outbreak of Ebola virus disease due to Ebola virus species Zaire Ebola virus. The second vaccination policy for consideration today involves the healthcare personnel. So again, we're focusing on vaccination of healthy, non-pregnant, non-lactating adults 18 years of age or older. The question is, should pre-exposure vaccination with the RVSV vaccine be recommended for healthcare personnel involved in the care and transport of confirmed Ebola virus disease patients at federally designated Ebola treatment centers in the United States? The work group proposal by strong majority again is recommend. The reasoning for this recommend is as follows, that operational ETCs, Ebola treatment centers with trained and vaccinated personnel is a part of public health preparedness. That this population is at high risk for occupational exposure to the virus. And again, it provides an added layer of protection in addition to other biosafety measures, such as PPE and engineering controls that are in place at these facilities. The proposed text for this second population is pre-exposure vaccination with the RVSV vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older who work as healthcare personnel at a federally designated Ebola treatment center in the United States. The third vaccination policy for consideration today has to do with biosafety level 4 personnel. Again, we're limiting our conversations to vaccinations of healthy, non-pregnant, non-lactating adults 18 years of age or older. The question is, should pre-exposure vaccination with the RVSV vaccine be recommended for laboratorians and support staff at biosafety level 4 facilities that handle replication-competent Ebola virus, species Zaire Ebola virus, in the United States? And the work group proposal by, again, strong majority is recommend. The reasoning for this recommend is, again, this population is at high risk for occupational exposure. And again, vaccination provides an added layer of protection in addition to the other safety measures already in place. The proposed text for this third population, pre-exposure vaccination with the RVSV vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older who work as laboratorians and support staff at biosafety level 4 facilities in the U.S. who are at potential risk for occupational exposure to Ebola virus. Thank you.
Okay, so now we'll go back to the first policy question for discussion and vote. And then we'll open it up to the committee to see if there are any questions, comments. Dr. Bernstein.
I just wanted to ask a question. Strong majority is not unanimous.
Strong majority is not unanimous, yes.
Okay.
We, for this, for each of the three groups, it was nearly unanimous. There was one person in each, one person who voted for shared clinical decision-making. And all the rest were recommend. There was no, there were no votes for do not recommend.
So allow me, please, to make a qualification here. It is the committee that will vote and make the recommendation. The work group may move to propose that this language be presented to us. So just clarification. The vote comes from the committee. The work group submits a proposal, and this is the proposed language. Please, Dr. Bell.
Just that in sort of another further clarification in terms of the feeling of the work group members, it's accurate to say that there were no work group members who were opposed to some sort of recommendation for each of these groups. There was nobody saying ACIP should not recommend in some kind of way.
Any other comments? Dr. Bernstein?
I was wondering about, I was still questioning whether there was value in documenting someone not being pregnant before they receive this vaccine, and I didn't know, maybe Dr. Ault could comment on that as an obstetrician.
Comment, Dr. Ault.
I think it's probably pardon me, the same issue as whether you're healthy or not. You know, when we get into the implementation, of course, we have an accurate urine test that can do that. And so we have the general principle that we shouldn't be giving live virus vaccines to pregnant women. So I think that would fall under implementation. So, and fine tuning that. If we, if we're going to define healthy, we can throw that in with it. So it seems logical to me. I didn't get to talk to the representative from ACOG at the break, but she might have an opinion.
Thank you. Dr. Messonnier.
Yeah, I have a question, and then Dr. Wharton had a question, but not wordsmithing, but I'm a little worried that the language here is too, when you discussed it in preparation for this policy considerations, it clearly had a tenor of being risk-based, and yet the way that the language is articulated doesn't exactly have that same sense of being risk-based. So again, not wanting to wordsmith, but that is the intention of the work group's proposal.
Very good. Thank you. Dr. Hunter.
I also don't want to wordsmith, but I do have a suggestion.
But you do want.
First of all, in context, I agree that avoiding clinical decision-making for this is appropriate because I think the decision is on more of an institutional level. However, I think occupational health, at least in my experience, has been, there are risks, and you go through categories of risk. And so I would, I think just the first of the three, want to insert something about that's something like a phrase that are at risk or are at high risk for Ebola infection due to responding. That's sort of the way what's running around in my head right now. I don't know if that is appropriate or not, though.
Thank you. Dr. Lee.
I sort of have that same thought, and again, apologies, I don't want to wordsmith, but to me, it's to capture what Dr. Messonnier said, which is that it's this group of individuals, healthy, non-pregnant, et cetera, based on potentially high risk of exposure to confirmed infected patients or infectious materials. And the reason I bring that up, and I realize we're not on recommendation 2 yet, but I want to make sure that it's both infected patients as well as their associated infectious materials, and I'm not sure that comes across consistently. And then to me, it seems like then we're saying we deem these three groups at potentially high risk of exposure. That allows for some of that, a little bit of latitude because of this question around BSL-4. But I do think that that group is still at potentially high risk of exposure, so it's important from an access standpoint for individuals. I also think it's actually important from a public health standpoint. I think we haven't talked about it as much. We've been really focused on the individual, but I do think that there's public health considerations here.
Dr. Cohn.
I was just going to suggest that maybe to capture this idea of there being a risk-based assessment when you say healthy, can you, in the statement, have the language about all of these recommendations apply to healthy, non-pregnant, non-lactating adults over 18 years of age, based on a risk-based assessment, and then have sort of parentheses in these three different groups, sort of to couch that risk-based assessment to and capture all three recommendations.
Dr. Eckert.
Thank you. Linda Eckert, ACOG. I have some concerns with excluding pregnant women because if you are working in a lab or you happen to be deployed, you happen to find yourself pregnant, you happen to be in a high-risk situation, the data wasn't compelling that there's an increased risk of safety in pregnant women. And I feel like it's an opportunity to consider language that might be a little less exclusionary toward pregnant women, both in this vaccine and then in general with the ideas of, fear of vaccinating pregnant women. Because we know if pregnant women get Ebola, how bad that is.
Thank you for those comments.
No,
Dr. Sanchez.
I agree. Just wanted to say that it's that the disease is so severe. We should allow the not make it an exclusion completely. It should be left up to that individual to decide, because a pregnant woman who develops Ebola, we do nothing for the fetus either. So, yeah.
Dr. Atmar.
So I want to remind people that this is pre-exposure prophylaxis, and so the vaccine is being given electively. But due to the relative lack of data in pregnant women, although the data available doesn't suggest an increased risk, because it is elective and in practically every circumstance can be withheld until the woman is no longer pregnant, we decided to go with the recommendation not to use it in pregnant women, adhering to the concept that we don't give live virus vaccines to pregnant women. And we really don't have a lot of data. We may get more data in post-exposure prophylaxis where it is administered to pregnant women to try and prevent them from getting a disease to which they may have been exposed to. And that may be a mechanism by which eventually this could be recommended for pregnant women. But we thought at this time it was prudent not to include pregnant women. There was some discussion about whether a pregnancy test should be done or not, and I'll defer to my OB colleagues on that question. And then the question about risk. We certainly had the at-risk for the BSL-4, and there was some discussion about people being deployed who would never come in contact with patients. But then there was also discussion that many times people who are deployed to an area in response to an Ebola outbreak, while the original intent was not for them to have patient contact, things are fluid and they might end up having a higher risk than was anticipated, which is why we thought those responding might be sufficient, and you could couch it, the risk language, in the text rather than necessarily in this particular statement. I don't think anybody was necessarily wed to it, but the discussion was that risk changes or can change once a person's on the ground after responding. Thank you.
Dr. Fry.
I was just going to also mention the obvious, I guess, or maybe not so obvious, is that we would also, if we took out pregnancy, would then follow to take out non-lactating. That's not to suggest I want to change the language. I just wanted to point that out.
If I may make one comment about the use of this vaccine in pregnant women. So we know, for example, that certain antibiotics should not be used in pregnant women because of the theoretical risk of joint damage, for example, in an animal model, and those are the fluoroquinolones. So we have a vaccine that definitely shows evidence of arthritis, and whether that would also occur in the developing fetus. So I simply throw that out for your consideration. This is not being considered, as we talked about before, this is being considered as pre-event exposure, prophylaxis. So, but that's my thought on that issue.
And, sorry, as well as viremia and perhaps dissemination.
Correct. Dr. Bell.
So if for a moment, if we could go back to the suggestion from a lot of the people around the table about potentially reflecting the concept of risk in the language, it sounds like is what people are interested in. And it seems like we want to balance reflecting something about risk in the language with the kind of implementation considerations that we would put more into a policy note. So, for example, where agencies that are sending people would have their own occupational health sort of policies. But am I understanding correctly that there's a fair amount of sentiment to somehow add some wording to the language reflecting the fact that that this is based on these people's risk or potential risk of exposure to infected patients or infected materials or something like that. Is that the sense that I'm getting?
Dr. Messonnier.
And I think it may just be in the framing. And so if you look at our other recommendations, it's not the recommendation language, which I think is meant to be precise here. It's the paragraph before where you explain why you made the decision that I think maybe would provide more context here. And so that's what Amanda, I think, was trying to kind of articulate, that in the paragraph preceding this, it seems like it would be helpful to articulate that this is a risk-based decision. That's not shared clinical decision-making exactly. It's a risk-based decision, which many of our recommendations have that kind of language to it.
Dr. Crum.
And I just want to remind the ACIP members that you will get a draft of the policy note for review and comment and feedback prior to. So if you vote today to approve the recommendations, there's still plenty of opportunity to provide feedback in how it's framed.
Dr. Fry.
I would agree with what Dr. Messonnier said. Obviously, we're recommending this vaccine for people who are at risk. We wouldn't be recommending it to people who would not be at risk. And because it's the risk factor that makes the decision-making difficult, we were anticipating providing that kind of guidance in the framing and afterwards, so to help people make decisions around should this person actually be vaccinated.
Dr. Hunter.
I very much appreciate that, and I'm really reassured by the commitment to incorporating risk into the guidance that goes along with this outside of the actual vote that we make. I'm a little concerned in the way things get implemented in institutions, in that the main thing, and sometimes the only thing that gets focused on, is what we actually vote on and the verbiage of that. And I'm not wedded to having the word risk in there, but I would just want to strongly make that point that if we don't have that word for risk in directly in the statement, then it could go both ways. It could go that an institution may overinterpret or underinterpret and not necessarily take the risk into effect, but just make an administrative decision, which happens sometimes.
Are there any other comments or questions? Yes, please. Dr. Wharton.
Would the proposed use of this vaccine, if there were significant adverse events that occurred, be covered by the countermeasures compensation program? I think Dr. Rubin might know.
Hi, that's a good question, actually, that came to my mind, and I'm waiting for response for that, and I'll get back to you.
Thank you.
Could I make a suggestion for the group that we go through each of these recommendations and then take a short break and try to do some of this wordsmithing to incorporate the language of risk into this prior to motions? It definitely sounds like there's a level of discomfort with that.
Dr. Talbot.
So I'm struggling a little bit, which is not usual for me. When it comes to, the thought is if your occupational health requires you to have this vaccine and you do develop an arthritis or an arthralgia, that can be problematic if you're a nurse at the bedside or a surgeon or you work in a BL4 space suited up. So it would be very helpful to know that these people who have stepped forward to take care of our patients and to do this research are protected if they do develop an arthritis. I think that's my big struggle.
Actually, your comment raises a very good question, which I should have thought of beforehand. But that is the arthritis or arthralgia large joint or small joint? And I think that's what you just alluded to. And again, if somebody has any information on that, it might be helpful.
Sorry, I missed that. Large or small? What?
Large or small joint arthritis or arthralgia. right, any other questions or comments?
Also, I'd like to say, it also might be little r or big R for risk, because if you are in a lab and you develop the arthritis, you may increase your risk of contracting Ebola. So it just...
All right, any more comments, questions?
Is there anyone from Merck who can speak to the type of arthritis that was developed? Do you guys have that information?
Sorry, I should have stayed over here. I do think, I will go back and verify, but I do believe that there was both large joint and small joint involvement, things like trigger finger, but there were like knee issues as well. So I think that both have been observed, but I will verify that.
Thank you. Are there any other questions, comments? Okay, so we'll leave this aside and we'll move on to the next proposed text. Dr. Choi, please.
So this is the second proposal text. So pre-exposure vaccination with the VSV vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older who work as healthcare personnel at federally designated Ebola treatment centers in the United States.
Comments? Dr. Lee.
Just to clarify, it no longer says involved in the care and transport. Is that, I want to make sure that it's this wording and not the wording in here. In
So
part because
I'm
it
sorry.
answers my question
Yeah.
around infected materials.
Yeah, it's this.
It's this wording.
Yeah,
Okay,
yeah.
great. Thank you.
So bring that to the attention of the voting committee, that the wording in your handout is different than the wording on the screen, and it's the wording on the screen you will be voting on.
And just to clarify, this would be persons identified at that treatment facility who were identified to be at risk, not every individual who worked at that treatment facility.
Additional comments, questions, or clarifications? Dr. Hunter.
So by removing in the care and transport of confirmed Ebola virus,
I'm sorry.
yeah. That's the phrase?
Yeah,
that was
I'm
removed?
sorry. Yeah, it should say care and transport. I'm sorry. This.
Okay, so let me go back. So the correct language is the language in your handout.
Okay.
And not that on the text, on the screen. We will wordsmith, we will correct that for the next round where we actually make the motions.
Okay, but I still have, and then I'm going to change my comment a little bit, which is maybe that's a little too specific of a risk to mention. And, you know, just healthcare personnel is not specific enough, but there might be a little bit more than care and transport that could be at risk. I can't think of it right now, but yeah.
Dr. Atmar.
Well, it would be the laboratory personnel who work in there, and whether you consider them involved in the care directly, it could be misinterpreted. So the intent was healthcare personnel, at risk, which would be those involved in the care, those involved in handling samples and cleanup after of the patient's room afterwards or whatever. So that was the intent, that it would include all individuals surrounding that patient and his or her clinical specimens.
Yeah, and just to add on, that the healthcare personnel definition that we had initially that we are, I know, still editing, but it had to do with people involved, direct and indirect patient care, so involving people who are support personnel as well. I mean, we all recognize that it's not just people who provide direct care, but who also do the waste management after confirmed cases and those personnel as well.
And
Dr. Fry.
That's what I was going to just basically say. So the transport people, I think, would be included under the healthcare personnel definition that's provided. And they give a big, for example, category, which the transport of the patient would most likely fall under. So we could actually take it out.
Further comments, questions, clarifications? All right, I see none, so let's move on to the proposed text number 3.
Okay, pre-exposure vaccination with RVSV's vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older who work as laboratorians and support staff at biosafety level 4 facilities in the U.S. who are at potential risk for occupational exposure to Ebola virus.
Open for discussion. Dr. Szilagyi.
I like this wording, and the phrase "who are at potential risk," the more I'm listening to the conversation, the more I think that that phrase should actually be, for me, in each of the other two, and not just in the framing.
Well taken. Please, Dr. Fry.
No, I think that would be a nice solution.
Any other comments, questions, or clarifications? Okay. So I think what we'll do now is we'll take a 15-minute break so that... All right, so we will do 15 minutes. The chair was not overridden. And we'll be back at 10 till.
With revised language for
yes.
consideration for, to make the motion. The idea would be to make the motion before lunch, before the public comment period.
Yes. Okay, so let's review the amended language, please. Go ahead, proposed text number 1.
With RVSV vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older in the U.S. population who are responding to an outbreak of Ebola virus disease are at potential risk for exposure to Ebola virus species Zaire Ebola virus.
Open for comment, questions. I see, yes, Dr. Sanchez.
No, we were just discussing this. I would prefer to see the non-pregnant taken out because this becomes, the way it's written, it's almost like the non-pregnant woman would not get it in any circumstances. And I think that it is a risk, and if she is at high risk for whatever reason, I think that should be still an option. And for post-exposure, if we recommend it, it's going to be two different. This is the way it's worded. It's almost like you're really so concerned that you don't want to give it at all, and then post-exposure is going to be okay. Yeah.
Dr. Fry.
So again, I'd just like to remind everybody that we're talking about pre-exposure, and I understand that there's concern about the difference between pre and post-exposure. Typically, post-exposure is a higher risk. I will say, if I understood the FDA comments earlier in the for your recommendations, that there was people who were pregnant could potentially be vaccinated, or people with comorbidities could be vaccinated. So our recommendation is only for pre-exposure, and at this point in time, given the limited data that we have, we feel more confident making this particular recommendation. Certainly, if there's major outbreaks or overwhelming cases, and people are exposed who are potentially pregnant or maybe even pregnant, that consideration would be swept away, perhaps.
Additional comments? Dr. Cohn.
Would people be more comfortable if we paralleled this to our other immunization recommendations where we don't include non-pregnant, non-lactating adults in the voted on recommendation, but then we have a contraindication or a space where it says it's not recommended for pregnancy or lactation or women who are lactating, or do you feel like it needs to be in the language that is included here?
Dr. Sanchez.
That was my point. I think that in the discussion, it could be stated that we don't recommend it, but it can be a personal choice or some sort of a way out that if it is high risk enough that it could be done. But I think the way it's dated here, it's almost like she's not going to get it, even if she wants it, unless she pays for it.
Dr. Bell.
So can I just go back to what you just said, Dr. Cohn, in terms of the idea of making the language parallel to other recommendations for live virus vaccines with respect to these issues of pregnancy and lactation? I haven't looked at my other work group members, but I think there's an argument to be made for having the language be parallel to other relatively new vaccines that are live virus vaccines.
Comment? Question?
So-
Dr. Eckert? Sorry.
I would encourage consideration of taking this out and putting it down below, simply because this isn't the same risk consideration if you contract the disease as some of the other live virus vaccines. It's so much more harmful to the pregnant woman and to her fetus. And the second thing is I agree that it would be good to give the pregnant woman a choice. If she finds herself pregnant in a situation where she is in Ebola risk, my fear is that, again, will lose a choice of whether or not she could receive this vaccine if it stays written as it is.
So I just want to remind everyone that, for example, on the adult schedule, live virus vaccines in the columns for pregnant women are do not give, but it's not in the language of the recommendation, exactly.
Dr. Fry.
I hate to ask this then, since if we're considering taking out pregnant, non-lactating, do you want to also take out healthy? Just a question.
Go ahead,
Well,
Dr.
following
Poling.
what Dr. Cohen just said, we should mimic the live vaccine recommendations. However we've done that, we should follow it the same way for the healthy.
So it is the healthy versus immunocompetent, that language is, I don't know that the word healthy has been used in prior recommendations. Certainly immunocompetent, for example, is used in the zoster recommendations. Do you know, Dr. Oh, no, or different comment?
Ms. Bott.
I don't know what healthy means. Does that mean that they don't have an acute illness? So if we're going to say the word healthy, I think we need to put it in context to what we mean.
Yes, and that was mentioned earlier by Dr. Talbot, and we were going to look into what a good definition would be. Typically, it would refer to people who don't have much in the way of comorbidities. Usually, if a person has a slight illness, like a cold or something, that would not prevent them or preclude them necessarily from receiving a vaccination.
Dr. Even.
Carol Hayes with the American College of Nurse Midwives.
Sorry,
so
Dr.
I have a
Hayes.
question. Yeah. Instead of saying healthy, should we be saying immunocompetent? Just thought I'd throw another bone on the table.
Dr. Atmore.
I think that would be consistent with the way some of the other adult vaccines are recommended into different groups. So I was going to propose something similar.
Are there any more comments on this particular? Dr. Sanchez has.
I'm for taking it out as well, because I think that we don't have a definition for it. It's going to be very difficult. What is healthy? What if they have diabetes but they're healthy? Is that a...
Dr. Bell, Dr. Fry?
I think there's a special chart for immunocompetent patients. And so we would could handle it the same way for that as we do with the pregnant women.
Ms. McNally.
From the consumer perspective, I think it's important to have the consistency in the recommendations to lead to a clear understanding of how these recommendations work.
Any other comments? So what we'll do is, if there are none, then we'll work on this during lunch and then come back. And we'll make the motion at that time to accept this particular language. All right. So Dr. Fry.
I just want to make sure there were no other thoughts about changing something before we. Yeah.
Are people comfortable? Should we go through the next two before adjourning?
Pre-exposure vaccination with RVSV vaccine is recommended for healthy, non-pregnant, non-lactating adults 18 years of age or older who work as healthcare personnel at federally designated Ebola treatment centers in the United States who are at potential risk for exposure to Ebola virus, Zaire Ebola virus.
So as chair, let me see if I can preempt additional discussion. Let us remove the same type of language we talked about previously. Is that okay? And we can still leave in the rest, is that right? All right, any other comments or discussion? Dr. Atmar. Noted. I'm sorry,
The
Dr.
comment was to add and before the who are at potential risk. Thank you.
Did I see another hand go up? Oh, Jeff, go ahead. Sorry.
Thank you, Jeff Duchin, IDSA. There was a question that came up at the break around revaccination if particular people who have ongoing exposures, obviously not the first responders, but the lab workers, for example. What is your thinking?
Dr. Fry.
So we don't have enough information to recommend a revaccination or to not recommend a revaccination. That question is being studied as we speak, and that will be forthcoming, a forthcoming recommendation after we have a chance to review data.
Right, and I remind the voting members and all in the audience that the ACIP has the right to revisit any recommendation as new information is available, so we can bring this back again. Any other comments? Dr. Lee.
I just wanted to clarify, for the federally designated Ebola treatment center, we're speaking specifically about anyone attached to the unit, including environmental services or things like that, but not, like, when I look at the names of the centers, I think of the entire institution versus the specific unit caring for Ebola patients.
Yeah, right. I think, potentially that could be at the potential risk part. So certainly not everyone necessarily that works at that facility, because that facility treats patients other than Ebola patients, but people specifically, working with confirmed patients.
That's great, and the text would
I
be
think
great.
the name of the unit is Ebola Treatment Center, so it's not the hospital, it's the specific unit that's
great. I think maybe just in the text or whatever, that'd be great.
Additional comments? All right, then let's move to the third proposed text. Again, to preempt any further discussion, we'll remove the healthy non-pregnant, but go ahead, please. Read.
Okay. All right. So pre-exposure vaccination with RVSV vaccine is recommended for adults 18 years of age or older who work as laboratorians and support staff at biosafety level 4 facilities in the U.S. who are at potential risk of exposure to Ebola virus, species Zaire Ebola virus.
Open for comments. And the word "and," as Dr. Atmar points out, should be added. Anything else? All right. Go ahead, Dr. Pitt.
I apologize. And we are talking about the same immunocompetent or whatever wording as we've talked about for the other prior two.
That will be worked on in over lunch. Yes, go ahead, Dr. Sanchez.
So the way it's worded, this is just language, who work as laboratorians and support staff. So support staff is a different group of people, not the laboratorians who actually are supporting staff. I'm just saying the wordsmithing. It's not clear. You could say that these individuals work as laboratorians and support, anyway. you're talking about laboratorians as one group and other support staff as another, right?
Do you want to offer comment on that?
So it's sort of a catchphrase, support staff, and it would be specifically for people who would be at risk of contracting infection. So again, those types of decisions would be made at the level of the institution. They would define who would and would not be at risk.
Yeah, so I mean, maybe just to clarify if I understood correctly, so it's not just laboratorians that work with the viruses, but these labs need to be maintained, and so there are people who are involved in the maintenance of these laboratories and that sort of thing that are not necessarily laboratorians, and so we kind of put them as support staff. But if they have to enter a BSL lab that at some point had Ebola virus in it, they certainly could be a potential risk. So that's the terminology that we were trying to get at.
Yes, Ms. McNally.
Is there any reason why we wouldn't want to go back to the definition that is healthcare personnel definition, page 10 in the first set of slides, where it says, let's see, I would go back to those involved in the patient care who could be exposed, because it gives examples, e.g. clerical, dietary, environmental services, laundry, security, engineering, facilities management, administrative, billing, and volunteer personnel.
Sorry, we're talking about BSL-4 labs, so laboratorians and their associated personnel. So we're not talking about healthcare personnel per se here.
No, I understand, but I think that some of the people that you're identifying under sports support staff would be the same, and I'd like to see consistency in language to the greatest extent possible.
But I'm not sure how we would fit that HCP in there.
Okay, I understand.
Yes, Ms. Mata.
I wonder if we could, instead of saying support staff, say laboratorians and the associated staff. So because support to me is someone who is entering data, and I don't think of someone who might be doing the housekeeping in that area.
Dr. Atmar.
We could say other staff at risk rather than support staff. Change that out.
Other staff at risk? Yeah. Does that address the issue? All right. Any additional comments? Okay. So at this point, we will take a break for lunch. We will come back at 1:20 for revisiting the Ebola vaccine wording and then the motions. And then that will be followed by public comment and then the vote. So, hour and 15 minutes. Thank you all very much. Okay, so welcome to the second half of today's session. We're going to go back to the Ebola vaccine language and put that up for review. So we've made a combined slide of the language, and if it is acceptable, we will do a combined single vote to approve all three at the same time. I will need, of course, a motion, okay, to approve all three, and then a second before we can do that. So this is what is put before us. We don't have to do it this way. We can go back and vote on each individual language, each individual slide, individual language, if you wish. So, you want to read that for us, please?
Yeah, sure. And I guess I would just also say that for the language about the healthy and that sort of thing, we did look back at previous language for other live vaccines, and the terminology that they use in the recommendation language varied. And so what we decided to do is go back to what the FDA indications are, which is adults 18 years of age or older, with the idea of then talking about pregnancy and immunocompromising conditions and other concerns separately in the policy note. So the combined option as it reads right now is pre-exposure vaccination with the RVSV vaccine is recommended for adults 18 years of age or older in the U.S. population who are at potential risk of exposure to Ebola virus, species Zaire Ebola virus, and are responding to an outbreak of Ebola virus disease, or work as healthcare personnel at federally designated Ebola treatment centers in the United States, or work as laboratorians or other staff at biosafety level 4 facilities in the United States.
Open for discussion. Dr. Fry. Oh, no, let me just, you may make that motion, but just a second. Any further discussion or comment?
I just wondered whether instead of "and" at the end of that third sentence, whether it should be to Ebola virus, they're at risk because they are responding, they work.
Yeah, I think we can work that out.
Sorry.
No. It's a good point, but I think we can sort of fine tune that as we publish it. Yeah, I mean the intent of the vote is not changed by I think that word. That's correct. Your grammar school teacher would be very proud of you. Okay, so I'd like to open this up for motion to, go ahead.
I would like to make a motion to approve the language with the idea that we'll add the grammatically correct language or verbiage.
May I have a second?
I'll second.
Dr. Alt, is there any further discussion? Okay.